Feel like a joke to begin with to lighten the mood in your biostats. Okay. Well, this weekend I was gonna go out and have a nice night on the town. I've ended up paying like all this money for a limousine, and then the guy canceled on me in the last minute. I had nothing to chauffeur for it. Thank you. All right. Okay, so a little bit about sensitivity and specificity. So what does sensitivity mean? Anyone know? All right, sensitivity, when we're talking about this, and this is usually going to be in regards to talking about tests we're performing, right? So for instance, if you're trying to diagnose a disease, say for instance, HIV or something like that, like you need to know how specific and sensitive your tests are going to be. Basically, sensitivity is trying to figure out, okay, if I test these bunch of people and I know already, so I kind of a priori know who has the disease and who isn't, how likely is that test going to tell me that those people actually have the disease, okay? So it's looking for to see like how many of these tests are actually going to be positive and people actually have the disease, right? And again, that's good because you want to be sensitive. You want to be able to detect that disease when it's actually present there, okay? Now, specificity is going to be kind of the opposite there, right? So again, people who do not have the disease likely should test negative. So again, when you have a very specific test, you're going to find that when you test a group of individuals, say you know what their disease status is beforehand, all those tests should come up negative if they do not have the disease, okay? Now, you're going to find all tests that we perform clinically have 100% sensitivity and 100% specificity. Absolutely not. You're going to find there's going to be some trade-offs in between these. You can have tests that are highly sensitive but not very specific, and vice versa. You can have tests that are not very sensitive but can be very specific, right? So we'll talk more about that in detail a little bit later in the epidemiology section, but it's kind of where we're kind of introducing it at this point, right? So again, this is kind of looking at, okay, well, how many false positives versus false negatives? This is where we're starting to get into that as far as when we're actually trying to diagnose something via specific test. So looking at talking about the predictive value. So again, we can look at individual tests and try to see like what's the positive predictive value, what are the negative predictive values, right, to tell us how likely is it when I test a person that if they truly have the disease, they'll be positive. If they don't have the disease, they'll actually be negative here. Okay. And again, imagine if the test was positive, what is the chance a patient actually really has the disease? If you have a really sensitive test, it's going to be pretty high for the most part. If the test is negative, what's the chance they don't have the disease? It's going to be that negative predictive value we're going to be talking about there, right? So that way, if someone really does not have HIV, they come back negative on that ELISA test or whatever test I'm going to be doing for those patients, okay? And so we have a quantified number that shows up, either a positive predictive value or a negative predictive value. And then based on that, this can kind of tell us how likely is it, how well is this test going to perform in a specific population. So the nice thing here is we can actually apply this to specific populations and give us an idea of how good these tests are going to be. And again, this kind of goes back to that first section where we talked about, how the tests can change based on if you're dealing with a population, say, of, say all healthy individuals, what was the likelihood of, or what was the rate of HIV in a group of healthy individuals? Probably pretty low versus if I had a population of IV drug abusers. What did you expect for that group? Probably higher, right? So again, knowing the prevalence of disease before going in helps to really inform a lot of these tests. It's going to tell us what that positive or negative predictive value is. So that way, remember we were saying that even though really highly sensitive tests, there's going to be some people that slip through. There's going to be some false positives, false negatives that happen with any test, right? This is going to be the nature of it. So looking at this, you can find that, and again, I'm not going to have you specifically calculate this on the exam, but I'm asking, what is the positive predictive value? What does that help us with, as far as trying to identify disease in a patient? And so basically, the math is pretty simple though, and usually you can kind of set it up based on this kind of this grid here, where you'd be looking at whether or not the disease is actually absent or whether the disease is present. And normally, when you're kind of setting up what the specificity and sensitivity of these tests are, you already kind of know beforehand, because usually you're kind of testing it along with like a gold standard, right? So for instance, imagine like what's the gold standard for like TB, or the gold standard for diagnosing it. Yeah, like a quantiferin test or something like that is going to be, kind of like a gold standard. But you can use like the PPD test to compare to that to see, okay, well, I know who has the disease, I know who doesn't, or if you have like a chest X-ray or something to help you out. So again, you're comparing these tests, and you can kind of get an idea of like, okay, well, is the disease absent or is the disease present? And then you look at whether the test itself was abnormal or normal, right? Normal being, let's say, no disease, abnormal being that yes, the disease is present, right? So again, looking at this, we can get a total here of, okay, so these are all the people who had an abnormal test. And then, again, note here, disease absent, disease present. Some of these people are going to be incorrectly identified. We just know that's going to be the nature of some tests. You're going to have some people that are going to be incorrectly identified here. And then you do the same thing here, and then based on these will actually help to give you an idea of what the actual positive and negative predictive values are going to be. Okay, and this is going to be very dependent on the population you're dealing with. Again, who has a disease and who doesn't, kind of normally. Okay, so this is what we call Bayesian statistics, right? This is Bayesian logic we're going to be applying here. We're going to be interpreting a lab value that we get based on the population that we're dealing with beforehand, right? So again, if I know I'm dealing with an IV drug abuser, I know that they're inherently going to be more likely to have certain communicable diseases, right? If I'm dealing with someone who has hypertension beforehand, I know they're going to be likely at risk for certain disease states. So based on that, this is where we can help to have the population in context to inform those lab results there, okay? And so again, looking at these Bayesian statistics, this is where we come into probability versus odds. Now, when you're looking at this, likelihood can be expressed in either way. So some of it can be expressed in probability, some in odds. Basically, probability is just the times that an event will occur over the fraction of times you'd expect to see it in the course of many trials. This is usually we're going to see the probability ranges between 0 and 1, right? So again, usually expresses like a percentage here. And then if you want to flip it around, you can say the odds are basically going to be the times that the event will occur divided by the times that the event does not occur. It's a little bit different. Just know that in a lot of cases you're going to find that, like we were talking about, like, probability is usually going to be good for things kind of moving forward. Odds are going to be things where we're kind of looking retrospectively as a general kind of cut point there. But just know that you can basically the math is very similar, but just know that odds and probability are a little bit distinctly different there. Okay, so again, we're looking at the likelihood ratio. So this is basically going to be defined as the probability of obtaining a positive test result in a patient that actually has the disease. And we divide that by the probability of getting a test result in a patient that does not have the disease. And it seems a little dense so far, but stick with me, okay? So again, looking at sensitivity, right? And sensitivity is telling us, okay, if they actually have the disease, what are the probabilities I'm actually going to get a positive test result? And then you divide that by 1 minus specificity. Specificity telling us that they don't have the disease, they should get a negative test result. And so what we're going to do is we can actually have what we call these pretest odds and apply those to that likelihood ratio and give us an idea of what these post-test odds are going to be. And so the idea here is we're trying to get more specific and trying to figure out, okay, well, starting with my pre-test odds, what are the likelihood I think this patient actually has the disease, and applying that to the test that I ran, it'll give me hopefully better post-test odds that I can correctly identify that disease, whether the patient has it or does not. And so again, you have to know enough about the patient beforehand to actually make some correct assessments here. So again, knowing if they're an IV drug abuser, knowing if they have a history of cancer in their first-generation relatives, these sorts of things can help to inform the pre-test odds, and then applying that to that test that's positive or negative, and getting some new post-test odds. So we'll talk a lot more about that a little bit later on when we get to the epidemiology section. But again, I just want to kind of introduce the concepts at this point. Now, moving into sample size, what do we say sample size helps inform in a study? Start with a P. Power, yeah. Remember, sample size is going to be directly related to the power that we have in a study here. So again, a lot of studies you're going to find are going to run with samples that are just way too small, right? So again, what's kind of a minimum number of patients you think you need in the study before you can say this is probably good to start getting some good conclusions from? Like an N of, I think 30. 30 is usually like kind of the baseline number that you want to look for when you're trying to get at least enough power to get any kind of statistical information out of that, right? So for instance, this is why I actually like doing test analysis on tests with you guys, because of the fact that there's roughly 60 of you. We can actually get some pretty good analysis out of that. Now, if I was running a test, or say I gave a quiz and there's only 5 people taking it, can I get a lot of information out of that? Not really as much, because again, there's going to be a lot of outliers. But the more power I have, the more N that I have, bigger sample size, the more likely I am to the outliers will cancel out one another, and you can actually get some good statistical results from that. So for instance, when you do like the EOR test, if I have one person taking the ENT test that I review, I have an N of 1. Can I take anything from that? Not really, because it's just an independent case versus when we look at 60 and get a lot of information from that. So that's a good. Typically, a lot of studies tend to be underpowered. Now, when it's underpowered, what type of error do you think you're more likely to make? Well, the slide says type 2, but what is a type 2 error? That's where you're saying that there's no difference between the groups when there actually was. You failed to detect a true difference here. So in this case, do you reject the null hypothesis? You don't, right? Because what is a null hypothesis? there's no difference between the groups, right? So in this case, if I have too small sample size, my power is too low, I cannot detect that difference, and I could falsely conclude that, yes, I cannot reject the null hypothesis, there's no difference between these groups here, when actually there was. Say I went from 30 patients and I moved it up to 300 patients, maybe I could have found a difference there. And at that point, we would have an adequately powered study to actually find a true difference, okay? So that's a type 2 error. And again, you're going to find that a lot of studies that are done out there typically tend to have a very small sample size, tend to be very underpowered for the most part. And many times when you're reading the literature, oftentimes they'll have a limitation section, and that's the biggest thing they'll say is, hey, we didn't have enough people to really kind of power our study to see what we're actually looking for. And now, what are some hindrances to getting a good sample size? It could be cost, right? It could be expensive if you're paying people to come in and have something done. What else? Type of population you're dealing with is somewhat rare. So for instance, we're dealing with, we do run some clinical drug studies on children with spinal muscular atrophy. It's a very rare genetic disorder, and so it's hard to find enough patients to really get good sample sizes for that, right? If you have even a dozen patients, that's rare. You'd have that many, right? What other things? Funding is probably the biggest thing, but again, could just be, what kind of sample you're pulling from, who do you have access to, what kind of resources do you have available to you. All those things can help to inform that. So there's a lot of reasons why you have small sample sizes that can occur here. And again, I always like to look at like literature coming from like the sports medicine sort of stuff. Oftentimes it's like usually grad students who are doing it like with their buddies, and so it's usually like, oh, we did like strength training resistance in like 5 well-trained athletes, and it's like, well, those are the other dudes in your class probably, based off of that. So again, under powered. However, you kind of use what you got, because again, you want to graduate at the end of the day, right? Anywho. So looking at sample size, typically there's a couple ways you can do this. So there's kind of an ad hoc way you do it, where basically you're going to just kind of collect data as it's coming in, right? Or for instance, maybe you want to, if you find that you actually don't get the results you're looking for, you kind of just continue testing and continue on until you actually find something. Again, why do we not like this? Just reanalyzing the data over and over again. Yeah, you're more likely to make a type 1 error. Right? Type 1 error, as we said, is when you say that, yes, there is a difference, we reject the null hypothesis, but it was actually just random chance we found that, right? And the more tests you do, the more likely you are to find that type 1 error. Remember, the more times you run the science over and over again, the more likely you are to find that error just by chance alone, right? Because again, less than 0.05, it's 5%. That's still a 1 in 20 chance you're going to find something, right? So again, the more times you run that, the more likely you are to get something that's not actually true there. Conventionally, typical, a lot of studies will do is they'll do power calculations. They'll actually do studies, they'll determine beforehand, before they even start the study. They're like, well, what kind of effect size are we actually looking for? What kind of sample size do we need to get to actually show this kind of difference? So an example here would be like, say we're doing a new medication for blood pressure lowering. You could say, okay, well, I want to show a difference between this brand new medication I have versus the gold standard. I want to show a 10 millimeter mercury of difference in systolic blood pressure, okay? And so they'll take that number and they'll figure out how many people they need to actually show that difference there, whether it be 30, whether it be 300, 3,000, whatever the case may be. They'll do that power calculation, okay? So a lot of times studies will do that, but they may still fail to meet that based on things like eligibility criteria or like getting patients to come in. It just depends on what the case may be. But that's kind of the most conventional way to do that, is a power calculation beforehand, okay? Tells you how many people you need to show the difference that you're looking for, okay? And then sometimes you'll find there's certain adaptive trials where they'll have certain phases where they've decided, hey, we want to modify the study to modify the criteria potentially. Sometimes you'll see this with like really large clinical trials. They'll do this. It could either like shorten a trial, could lengthen it. So for instance, there's been some studies where they planned on going for 10 years for certain outcomes, and they found such strong outcomes so early, they said, like, we don't even need to continue this. We can go ahead and stop it early. We already know there's a real difference here. Sometimes if they can't find anything in that 5 years, maybe they'll extend it out to 10, right? And that's usually built in to the analysis beforehand. It's kind of built into the protocol. And again, confidence intervals are directly affected by the sample size we have. Typically, if you have a bigger sample size, what does that do to your confidence intervals? Makes it more narrow. Why is that? Exactly right. So again, if I was looking at, say, average IQ of PA students, and I was only looking at the 60 of you guys, I would have a pretty good idea of what the population might be. But I'm going to have a pretty wide confidence interval with that, because there could be outliers. There may be something that's directly affecting you. Maybe the water in Florida is causing you to have higher IQs than normal. Who could say, right? However, if I were to increase that sample size and include all the PA students in Florida, I'm getting closer to that population that I'm actually looking at. I have a bigger sample size, my confidence interval will start to get more narrow because I'm more closely sure that this is the actual population average. Okay, I'm assuming it's like in the 160s based on your guys' performance, right? That's not the high IQ. But, anyway, I'm saying you guys are smart. But again, looking at that, oftentimes you can say that, you know, by determining what kind of confidence intervals you're looking for, that can also help you to determine how many what sample size you need to kind of achieve that. So again, just know that the bigger the sample size, the more narrow the confidence interval is going to be. Okay. Okay. So any questions on the end of that section? Okay. So moving on, let's go into the last one, 9. We're putting it all together, right? Hopefully everyone's watched all the videos. Everyone has a firm idea of how statistics work, right? You're all that confidence. So getting into it, how do we choose a statistical test? Like, how do we decide what kind of test we're going to run? A lot of it comes down to things like what kind of variables are we dealing with? What's another big determinant of what kind of test I'm going to use? What about what type of distribution I have, right? Remember what you call that when you have you're using like a normal distribution? What kind of test I can use? That term started with a P as well. Parametric, right? I can use like parametric test versus non-parametric test. This is where there's going to be some tables here that kind of help us out to determine what kind of test you want to run based on the type of information you're looking at, the type of variables you have, whether you have normally distributed data. Okay. So looking at this, first off, let's look at continuous data from Gaussian distribution. What's an example of continuous data? Temperature. Temperature is a good one. Continuous data, right? Because again, the difference between 1 degree centigrade and 2 degrees centigrade is the same difference between 99 and 100, right? So again, it's a continuous data. What's another example? Anyone at all? Weight could be a good one. Age could be a good one, right? So this is in stark comparison to something like, say, ordinal data, like ordinal variables. What would that be an example of that? Yeah, so think about those Likert scales we use. Like, for instance, when you're doing my evaluations for this class, and you're going to say this class was very interesting, I strongly agree. That's a Likert scale, right? It's ordinal because, again, the difference between strongly to just regular agree is not really that well defined between, say, neutral versus strongly disagree, right? So because of that, again, that inherent difference between values is not going to be as explicit. However, there is an order to it. That's why it's an ordinal variable, right? And then what was the other form variable we had? Nominal, right? Nominal means name, kind of referring to what? Just categories, right? So I can say red eye, blue eyes versus green eyes, red car, blue car. What else? Male, female. Again, there's no inherent differences between the groups necessarily. Not one superior than the other. It's just that they're different categories, right? Different kind of buckets you can put individuals into. Okay. Good. So let's say we're looking at continuous data. That's the most common thing you're going to run into in the medical literature here. So first off, we can test for things like Gaussian assumptions. When I say testing for a Gaussian assumption, what does that mean? Yeah, I'm looking to see is the data I'm pulling from a normal distribution, or are there enough outliers that are kind of skewing the data? Maybe it's not normally distributed. So you want to test for that because that'll inform what subsequent tests you can do on that, right? So for instance, here is where we're going to do things like normality tests, right? Those are the ones that I consistently fail. Not pass one yet, but outlier tests, they can all help with that. They kind of determine, do you have normally distributed data or not? If this passes, if you say, yes, this is normally distributed data, right? Which just means if I pulled any random sample, that the sample I have right here in front of me is not statistically different between any other random sample out there, right? Showing that I cannot reject the null hypothesis there's any difference in the groups. That's what you're looking for. So once you pass that normality test, then you can start to use what type of statistical test? Parametric or non-parametric? This is where you start to use parametric tests, right? So this is where we're going to get into using these. So if we just are describing one sample, this is very easy. This is very descriptive statistics here. So we have things like frequency distributions. You can use things like a sample mean. How do you calculate a sample mean? Add all the values up, divide by the number of observations you have, right? Again, it's just that simple. We have things like minimum and maximum values. We have ranges. You can get the interquartile ranges, like the 25th and 75th percentiles, standard deviations. That can all be used just by looking at one sample, right? So I took all of your guys' IQ. I can get you just do very simple kind of descriptive statistics with that. Now, if I say I wanted to make an inference about a population, say I wanted to compare this group here in front of me to, say, the PA student population at a whole, this is where I can do things like one sample t-test. Okay, one sample t-test when you're going to be comparing the group, whatever sample you're looking at, to the population. It's called a one sample t-test there. More commonly, what you're going to find is you're going to look at things like head-to-head trials. You're going to look at where they're comparing two different groups together that are subsets of a population, and this is where you run into unpaired t-tests. Now, what's the difference between unpaired and paired? Yeah, paired may use the same subject. So say, for instance, I did a pre-post study. I say I had a patient who started on one medication, I switched them to another medication, then I was making assessments, right? So basically, the person can act as their own comparator. That was considered a paired sort of assessment there. I'd want a paired t-test in that case there. Twins, I could do the same thing. I'd run the study in parallel and then compare those two together because they share a lot of genetic information. They're kind of considered to be their own comparison. Again, not as commonly done. More often than not, you're going to run into these unpaired t-tests where you're going to be, everyone's independent of one another. Everyone only gets measured one time. Okay. Now, if I wanted to compare more than, say, two groups together, what could I do? Yeah, this is where ANOVA is going to be coming into play here. That's the analysis of variance. Now, why do I need ANOVAs? Why can't I just say if I have three different groups, just start to compare, group A to B, A to C, B to C? Why can't I just do that? Yeah, so multiple comparisons problem, right? So again, the more comparisons I make, the more likely I am to make a type 1 error, and I don't want to do that, right? I don't want to say that there's a true difference when really there isn't, just by running that study over and over again. But I remember when we were looking at that, the very first section, they're looking at hospital admissions data versus their astrological sign. It's 12 signs, and they're comparing all these different reasons for hospital admission. They found a ton of statistically significant findings there because they ran so many different comparisons that of course they're going to find something. So that way you know that if I'm a Pisces, I'm more likely to be admitted for hemorrhagic stroke. Is that really the case? I don't see anyone really shaking their head, which is good. But that should not be the case, right? Astrological signs really shouldn't be playing a big role here. So because of that, you only want to do that ANOVA test, and that will allow you to figure out, again, if there are a difference between anywhere within the different groups, but it doesn't tell you specifically which groups are different from one another. Okay, so go back to that kind of that runner example that we were looking at, where you had the three different groups: the non-runners, recreational, and then the elite runners. You can compare them together. Okay, so and then if you wanted to do an ANOVA, that would be a one-way ANOVA. And if you wanted to do, say, the paired group, so say for instance twins or the same person over more than once, as we're using a repeated measures ANOVA. Okay. Now, getting into linear regressions, remember, what did that help us to do? That's when we're talking about things like values predicting one value of another, right? So again, if I were to measure something like that fatty acid concentration in those cells, could that predict what the insulin sensitivity of that patient's going to be, right? So again, one value is going to help to predict another. That's where linear regressions are going to be very useful. And then if I have a lot of variables, a lot of say independent variables, that's where you get those multiple linear regressions. Okay. And remember, when I say independent variable, what does that mean? Independent means I'm setting that, the researcher is setting that. They're saying, okay, this is the variable I'm putting into the system, and then what you get out is the outcome, the dependent variable, right? Because the dependent variable is dependent on the independent variable. Okay, makes sense? So with a multiple linear regression, you can have multiple independent variables going in to try to predict one of those outcome variables. So for instance, in that one example we were looking at, you were looking at things like, lead, the effects of lead levels and age on creatinine clearance. Creatinine clearance is the dependent variable that was the outcome there, right? So you can kind of go back to that, think about different comparisons. You get an idea for, kind of get a feel for, what test is most appropriate here. Okay, so if I ask a question on a test, it comes up and says, hey, you have these three groups of people, you want to all compare them together, and you're looking for differences in performance of, say, a specific test. Which kind of test would you run? ANOVA, right? And again, I will tell you, it's normally distributed data. I'll say they pass a normality test, and then, what test you want to run after this? And I said there are independent groups, but there's 4 of them. You'd say one-way ANOVA, right? You just need that one-way ANOVA in those cases. Remember when you have like a two-way ANOVA? What was that? That's when you're factoring in another independent variable, right? So remember in that running example was looking at the running status, but also the age of the patient as well. So that would be like a two-way ANOVA in those cases. Okay. So again, keep in mind what kind of test would be appropriate based on the type of study I want to run. Okay. All going to be applications. It's all going to be very specific. Say, okay, well, how do you interpret what we're writing here? This is going to be kind of a wordy exam, and it sounds a little scary, but again, know your definitions, know what tests are appropriate for which kind of comparisons here. Okay. Now, let's say we have continuous data, say from non-Gaussian distributions, right? So again, remember with non-Gaussian distributions, I'm saying, okay, this is not normally distributed. There can be a lot of things like outliers, right? So how do I organize the data in those cases? Because if, looking at normally distributed data, the mean is really the thing I'm looking at, right? Means are not going to be good for non-normally distributed data because of what? What can affect the mean? Outliers very significantly can affect the mean value. So instead, what do I use? I use the median. Medians are insensitive to outliers. So by using that, I can then rank all the values, take away the actual numbers themselves, and just look at the ranks, and that's how I can get around and use these non-parametric tests for this data here. Okay, bless you. So again, when you're looking at this, you're going to find that the simple description of a group, only real difference here you're going to find is that you're looking at sample median. You're not looking at the sample mean. You're still looking at minimum maximum values. You can still look at the interquartile or the percentiles here. But again, the only thing different is the median instead of the mean. Okay. That also is going to change what tests you can use. So for instance, if I'm making an inference about one population, so I can use that Wilcoxon rank sum. If I'm using two unmatched groups, where I can use a Mann-Whitney test. Again, this is a big common one. You're going to use this very frequently. So for instance, when I was doing my study for my fellowship and I was looking at different management strategies for coral snake bitten patients, I couldn't get the patients to pass a normality test, the sample that I had, so I had to use a Mann-Whitney U test. I compared people who got early antivenom versus people who did not get early antivenom. And so I used a Mann-Whitney test to compare that group because I knew they're non-normally distributed, but again, they're unpaired samples. So Mann-Whitney was very good for that. And then if I had paired samples, though, I could use something like a Wilcoxon matched pair test. Okay, so you can understand which test you're going to use based on the parameter set in the question. Okay, looking at things like survival times, we had a little bit of talk on this on one of the lectures there. This is where you have things like Kaplan-Meier survival curves. Now remember, oftentimes when you're performing studies, do you always look at the full survival time? No, why not? Yeah, right. So it's kind of morbid, but like, can I run studies like for 50 years, wait for someone to die? No, this is going to be kind of impractical. But if I can look at median survival time, that's going to be very useful there. I suppose Kaplan-Meier survival curves can be good. I can actually compare different curves to one another to look at that median survival to see, say which group is living for longer, right? So for instance, I could do something like, say, just to go back to what we were talking about in pharm, CHF patients, those were on an ACE inhibitor, those that were not on an ACE inhibitor. I can compare those survival curves, and I'm sure there's a lot of studies out there that do that. You'd find the median survival time for those on an ACE inhibitor will be longer than the median survival time for someone who's not on an ACE inhibitor. Okay, make sense? That's what that's good for. And again, if I don't really kind of talk about it right here, it's probably not going to be all that important for testing purposes. So again, just the things we kind of reference back on the lectures, right? Those are the things I want to key in on here. So maybe a little extraneous information on these here. But the big thing is that Kaplan-Meier survival curves are looking at median survival time. That's the big thing they're looking at. And again, why don't I use mean survival time? There can be a lot of outliers there. Some people are going to live to be 120, some people are going to live to be 30, right? So again, you're going to find that because of outliers, that's why we use median survival times. Okay, looking at binomial outcomes here. So again, binomial just means what? Two different categories, right? So binomial is the nominal sort of data here, nominal variable, but there's only two of them. So man, woman, Chevy, Ford. Which one does your sticker focus on, right, on the back of your car? I'm from Palaca. I get a lot of that. Anyway, looking at comparing these two groups together, so again, looking at, say, people who are registered to vote, not registered to vote, whatever the case may be, it's binomial. There's only two samples here. You're looking at proportions, right? So you're looking at the proportion of people in one group versus another group. Very, very easy to do. You can do things like confidence intervals when you're doing that. But the big thing I want to know about here is what kind of tests can you perform to see if the groups are kind of, normally distributed, or are they going to actually be, one group is kind of more prominent than another. And this is where we can do things like Fisher's exact test, which is good for comparing kind of two unpaired or unmatched groups. And you can use the McNemar's test for paired groups. Those are kind of the two big ones you're going to see used when you have a binomial sort of thing there, right? So again, if I had, say, students who studied early in the morning versus studied early at night, that could be a binomial sort of thing. And then I could look at something like test outcomes, pass or fail. So I can do that, and that's or I can run these tests in order to find if there's actually a difference in, say, the time of the day that you study and how that does on your test results. Okay. So let's get into the actual bones of an article. So when you're actually looking at an article, what are kind of the different aspects you're going to be doing this. So why do we read the literature? Why do we read the medical literature out there after we graduate? To stay up to date. Isn't that what up to date's for? We can just read up to date forever, right? No, you're going to be very studious PAs, and you're going to say, I'm going to actually read the primary literature. I'm going to go back and actually read the studies. Why do we do that, though? Lots of reasons. Is there a new change in treatment, right? Maybe a new drug that came out or a new procedure that is superior to other ones, right? Or maybe there's some sort of new health problem that's coming up, right? So again, I recommend finding a select set of listservs that you happen to jive well with. So for instance, I get a lot of like toxicology stuff that gets sent to my email every single day, and I can kind of stay up to date, stay abreast of all the new recent developments, and that way I can, when I'm on call for the Poison Center, I can have up-to-date information to recommend to the providers I'm working with, right? If you work in ortho, maybe you have like an ortho thing that you get sent every day, either review questions or new studies that have come out, things like that. But basically, you want to stay abreast of the information, and the critical thing to learn now is how to be a lifelong learner. Okay, you can't just say like, well, this 2 years, I learned everything I need to know, and that's it. That doesn't work, right? And in fact, when you get out of here, you're actually going to feel like you don't know anything, which is totally normal. But once you actually start working and get some experience, you realize, okay, I can actually learn this stuff. And you'll learn to pick up a lot of things very quickly. And in fact, the thing about this generation, I think, is that you guys are much better equipped for learning things quickly on the fly than, say, older generations, right? Because again, when in doubt, what can you use to find information very quickly? Google it, right? Just Google it. You can Google a lot of things, right? But it's important to know kind of what resources to look at. So again, looking at the primary literature, being able to parse these things out. That's why we take this class. This is why we do this, right? So anyway, looking at the bones of an article, this is how when we actually go through and do these journal clubs, this is the different aspects we're going to be looking at. So when I say abstract, what is that going to be? Kind of a summary, yeah. So it kind of gives you the nitty-gritty details of an article, and usually you're going to find that most articles or most journals will publish the abstract and put the rest of it behind a paywall if you don't have access to it. That's why I strongly recommend getting involved in academia, where you can get access to the university libraries, because you have access kind of to a lot of really big journals out there, which is a very big boon. One of the big things I will tell people is like, don't just read an abstract and say, all right, I know everything I need to know about the study. What do you think are some problems with doing that? People could choose to maybe highlight certain points over others. Maybe they say, hey, look at this difference we found, neglecting like the 10 other things they didn't find, right? Things they couldn't prove were statistically significant. That's important to know. Sometimes they don't include important limitations, right? Because again, the important question you want to have is, does this article apply to my patient? Can I take this information and actually apply that to actual clinical actionable information? And again, if you just read the abstract, oftentimes you're not going to be able to get enough information here, right? So that's why me and my wife always joke with each other. She'll say, "Oh, I read this article that this thing happened." I was like, "Oh, well, was that in the abstract, or what was their sample size? What was the what statistical test that they performed to actually find?" That's the kind of stuff you don't see in the actual abstracts. They can be very important. And again, she usually likes to conk me on the head with something hard whenever I ask those questions. But anyway, that's the thing. The introduction. Introduction is going to be used for what? Sets the background, sets the story for like, why do we actually care about this in the first place, right? So for instance, when I did my research article, or even my research for coral snake bites, why do you think we care about coral snake bites? Specifically here in Florida. This is where they all live, right? So I just set the stage and be like, okay, this is why this is a big concern for Floridians specifically, because this is where all the eastern coral snakes live, and these are the big ones of toxicologic concern. So you say, like, this is why it's a problem, this is how many people they bite a year, this is how the outcomes that can occur. You're setting the stage for why you think this research is important, okay? Then you're also kind of framing previous research, what has been done in the past, and why this is informing what you're doing now, okay? Now, one of the most critical aspects you can look at in an article is going to be the methods, materials and methods. Why is that? You gotta know how they conducted the study, right? You need to know things like inclusion criteria. What's inclusion criteria? How do they select people to be in the study, right? What are the parameters people had to meet in order to get them in, right? So again, if they excluded, say for instance, you're looking at a hypertension trial and they excluded anyone over the age of 60, that's important to know because that skews your data quite significantly, right? If you're treating patients who happen to be geriatric. You need to know things like exclusion criteria. What is that? It's like make sure you don't include people you don't want to, right? So again, if you excluded people who are maybe on previous treatment for a disease or maybe they have previous cancers or whatever the case may be, those are things you want to know. You want to know who you're letting into the study and who you're excluding from the study to get an idea of like, is this applicable to my patient that I'm dealing with right now, okay? This will also tell you things like, how they actually went about finding the patients. This can tell you a lot of information about, was this from a big academic institution? Was it from multiple hospitals? Was it only from one tiny clinic? We'll give you an idea of what kind of geographic location you're dealing with. They tell you statistics tests that they are going to perform. They tell you the power they were shooting for. All these different things are included in those methods. That's why it's really important to read that. And again, this is when we do journal clubs, we're going to focus on that probably the most, even more so than the actual results that we're going to get. Okay, because again, if you can read the methods and materials and be like, this is kind of a bogus study. They definitely excluded some very significant populations here. It's really skewing their data. I don't think it's going to be a very good study. It doesn't matter what the results say. If you've concluded the study's no good, the results can say whatever they want, but it doesn't really, it's not important to you. Okay, then moving on, we have the results. What are they going to tell us? The results, what exactly happened, right? So again, oftentimes, do they include every single data point that they collected? No, that would be boring. No one ever wants to read that. They're going to give you basically the highlights of what they found. They'll find the things that were statistically significant, the things that were not, and try to just very plainly just say, here's what we found. Okay. Now, another important aspect of the article is going to be the discussion and the conclusion section, right? The discussion tells us what? It's where the author is going to then kind of read into the results and tell you what they think about it. Okay. Now, again, you want to take that with a grain of salt. Now, hopefully you're reading from a peer-reviewed article where someone else has also read that and says, okay, this is okay. But you want to be always taking things with a grain of salt and remember that, hey, this is someone's interpretation. But what do they think about the results? What did they think they found that was significant, was non-significant? What are the things they thought were challenges that could have led to the results that they found? Right? What are some things that maybe if they didn't find any differences, why did they think that? Maybe the study was underpowered, or maybe they were looking at the wrong sort of test result, or whatever the case may be. And then finally, you're going to have your references. Obviously, those are good because you want to always document where you're pulling information from. And guess what? When you do your graduate projects, especially GP1, guess what? It's going to look a lot like this right here, right? Again, most of you are going to be doing research review or literature reviews, not necessarily doing like bench research yourself, but a lot of it's going to look very similar to this. So again, it's good to have an idea of what a general article flow is going to look like. Okay. So you kind of went through all of these. Just be aware that abstracts can be very different from one journal to another. But again, depending on where you work, you'll kind of get used to those particular articles and kind of how they present their data there. Again, introduction needs to set the stage. It's kind of painting a picture. It's kind of like, imagine you're writing a book. Imagine you're writing, J.K. Rowling's writing Harry Potter. Like, you got to set the stage. You got to make sure, okay, here's a dark and stormy night. Harry Potter got hit with Voldemort. He's got a big lightning bolt, blah, blah, blah. Set the stage right, and then you can get into the rest of this is kind of where you kind of grab people in. I guess my interest in snakes may belie what house I might have joined had I gotten into Hogwarts. Interesting. Anyway, methodology. Remember, this is where we're going to get all the details on specifically how we actually going to perform this study. This is one of the most critical aspects you can read and try to understand. Okay, why are they performing the tests they're doing? Does it make sense? Did they talk about normality tests? Did they assume it was normally distributed data? Did they not? Those are important assumptions that can really skew the data one way or the other. Okay, but very, very important here. And then talk about the results is where they're just going to say specifically what happened. This is where graphs and figures are also going to show up. And that way you can kind of reference back to those good graphical representations, all the data, because again, you're not going to see every single data point. Then discussion, as I mentioned, mostly speculative. Again, this is where the author is going to be giving their 2 cents on what they think about the results here. So again, always take that with a grain of salt. And then obviously the references. If they don't have references, you should be very wary of that article. It'd be very odd they would not have any primary references, but most people do, especially if you're reading from a peer-reviewed journal. Okay, so again, how do you select which articles you're going to read? I mean, like, there's a lot of articles that get published out there. How do you select even what journals you're going to go with? How would you decide that? Just, I'm just going to read JAMA, or I'm just going to read The Lancet. How do you decide? You have to be selective. You can't read everything that's out there, right? So again, look at where you're going to be. What are you interested in? What are the things that you find to be most compelling? So for instance, I'm really into toxicology, so I read clinical toxicology because that is the journal that is, mostly aligned with that specialty. If I'm into pediatric emergency medicine, guess what? There's pediatric emergency medicine journals out there. You want to stay abreast of those ones that pertain to your job or whatever you happen to be interested in, right? So if you work in ortho, there's an ortho set of journals you read. If you're into critical care, you'll read those. So just keep in mind that you need to make sure, be very selective about what you're kind of keeping in mind. Anyway, again, skim the article at first. You don't have to sit there and figure out if I need to read every single detail of this, but kind of skim over, see if there's anything in the abstract that kind of grabs your attention. If it does, then you can start to delve a little bit deeper and kind of gauge the structure of the article based off of that, right? Because you can't read everything, but at least kind of see the things that may grab your interest. The abstracts can be very useful with this. And as I mentioned, concentrate on the method section because this will tell you if the study's bogus or not based off of incorrect assumptions that they're making, based off of weird exclusion or inclusion criteria, any of those things. So for instance, if in my study, if I said I'm going to exclude all children, would that be a problem, do you think, when it comes to snake bites? Absolutely, because again, children are very frequently bitten by snakes because they say, oh, look at that little colorful snake, let me pick this up, and they get bit. So that's a very important thing. You have to consider, what are the, who are they including, who are they not including, how do they actually analyze the data there? Okay, let's get into specifically how to do study design. So what are the different types of studies you may come across when you're out there reviewing the So there can be kind of two big delineations here. We're going to find there's both descriptive and explanatory studies. Okay, and when you get into the explanatory, this is where we're going to get more specifically into either experimental or more observational studies. And when I say observational, what do you think that means? You're just observing. You're just looking at see what happens with a group of patients. You're just looking to see what's happening. You're not having any direct intervention here, right? So again, this is where you're just seeing like, hey, what are the survival rates in people that have a particular diet? I didn't change their diet. I'm just looking to see what kind of happen to those people. Versus experimental would be what? Where I'm doing an intervention, right? So for instance, if I give someone a new drug and another group no drug, I want to see the differences there. That's an experimental trial. I'm actually introducing something different there. Descriptive, though, you're going to find these are typically going to be just much smaller in scope and much more narrow. And you're going to find which ones do you think you can draw the most conclusion from? Because we said correlation does not necessarily imply causation, but which one can provide the most level of causation here? The experimental trials, absolutely. So again, when you're looking at these different trials, if you're seeing like, hey, we did a case series, we had 2 patients we looked at that had this particular side effect from this drug. You can't really take a lot from that because again, it's only 2 patients. Versus if I did an experimental trial and I had 1,000 patients, gave 500 this drug, 500 no drug, and saw what happened, that gives me a lot more credence, right? I can take a lot more cause and effect from that because I'm actually doing the intervention. I'm actually finding out what happens to those patients there. That makes sense. So as I mentioned, descriptive studies are just recording events, observations, activities. There's no actual specific interventions that the provider will be making there. Again, they're not going to provide detailed explanation for the cause of disease. I can't say specifically why this person developed this particular outcome, but this is what happened. Or you're just describing what happened there. And again, it doesn't really give you any evidence needed to evaluate the efficacy of, say, a new treatment or a new new way of diagnosing something, right? So what are the benefits of using descriptive studies? Why even report any of this stuff in the first place? Because if it's something interesting or unique or new, you at least want to get it out there. You want at least people to start to think about it, because then what can you do after you do, say, something like a case report? You can make a bigger study about it, right? So for instance, say, hey, wow, it's interesting. I had this couple of patients. They happen to have this, genetic background, this ethnic background, and they developed this condition. That's kind of weird. It only happened in 3 patients, but that's weird. You publish that, and then you find, okay, well, let's do a bigger study about it. Let's go and do, let's look at a larger sample size, and that will give you more credence. It'll give you more cause and effect sort of relationships you can maintain there. So again, usually the starting point for more elaborate studies, but still important to publish there. So for instance, I have a case report that I was able to publish while I was on rotations. So again, keep your ears out when you're on rotations for interesting cases, because it can be a very easy way to get published relative to doing like a big experimental study. Basically what we had was a very sick child who ended up having, you guys remember, how do you treat C. diff? Oral vancomycin, right? Why do we like oral vancomycin? Doesn't get absorbed systemically, right? So it was a very good drug from that standpoint because it doesn't get absorbed systemically. This patient had such bad C. diff colitis that she actually ended up developing measurable and therapeutic blood levels because all that oral vancomycin was leaching through the GI tract into the bloodstream. That was unique. It was something that is not commonly reported. We say, well, let's report it, right? And so we were able to get that published. Again, easy, low. Did it cost us a whole lot? No, it cost me mostly just my time to actually write it up, but for the most part, you're going to find that those are a little bit easier to publish. They're descriptive. We didn't do anything different with the patient. We're just observing kind of what happened to them. Okay. Explanatory studies are going to be using comparisons. We're going to be comparing groups together to try to get a little bit more cause and effect out of this. As I mentioned, the experimental are going to get much more concrete conclusions about, yes, this caused this. It's more observational, you're going to find that you may not be able to make it that strong of a conclusion. So experimental, this is where we have things like controlled trials, clinical trials. Typically, this is where the investigator is having an active role in this. So for instance, imagine starting with a study population, breaking up people into the experimental group, and I have a control group. And control group just means what? They're my comparator group, right? So does that mean they get like no intervention whatsoever? No, they may get like, the standard of care, for instance. So imagine if you were trying out, say, a new drug for HIV. Could I just not treat a bunch of people for their HIV? No, that's unethical, right? So again, you may have them on gold standard therapy, and then you have an intervention with a new drug. We do that very frequently for a lot of cancer treatments, right? So with children's oncology, we do a lot of studies, and again, we don't just not treat kids' cancers. That would be very unethical. We go ahead and give them the gold standard, and we have another group that we use a new protocol, or we use a new drug for, or whatever the case may be. So again, control just means that they're either not getting anything, or they're getting kind of what the gold standard therapy for that condition is, okay? Because there's different ways you can kind of define that, and defining your control group is very important. Then you have your experimental interventional group, and then you're looking at, say, the disease outcome. So for instance, if I was comparing different cancer regimens, I was using different cancer drugs, and I was looking at, say, disease outcome, say, okay, well, they had progression of disease or they had remission, right? I can compare these groups together and then get an idea about, okay, well, what effect did this drug have on these outcomes, okay? You can take a lot of good cause and effect from that based on that. And then notice here, we're starting at the very beginning and then moving forward in time. You call that what? Prospective or retrospective? Prospective, right? So if I'm going forward in time, that's prospective. If I'm looking backwards, that's called retrospective, right? So you're thinking about your retro, I don't know, I guess you 90s kids, whatever you had in the 90s growing up, that was your thing. That's retro, right? So again, that's retrospective. You're looking backwards in time. So looking at observational studies, typically you're just looking at two groups, not actually having any active intervention here. But this can be useful when you're trying to explain, links between, say, disease states and certain outcomes, or certain exposures and outcomes here. And again, researchers are the bystanders, just kind of watching to see what's happening between these groups here. So this could be something where you say, just looking at the natural course of events over time. We are going to be gathering that data from the subjects, whether it be lab tests or history taking, whatever the case may be, and then trying to classify and sort the data. We can make some comparisons afterwards. The three main types you're going to run into are going to include our case control studies, some follow-up studies, and then cross-sectional studies. We'll go into more detail on what these are in just a second. Now, case control design, you're going to notice here, where are we starting at? In the future, right? And then where are we looking back? Looking into the past, right? So again, usually with case control studies, what we're starting with is we're starting with the outcome, right? So if we were curious about, say, for instance, lung cancer, how would I do that? Well, basically, I take my cases. Cases would be the people who developed lung cancer, and I would compare them to people that did not develop lung cancer, right? That's my control. That's what we call a case control design, where I have people who are my cases, they have the outcome I'm curious about, and then we have the controls that do not have the outcome, okay? And then what do you think I look for going back in time? Look at risk factors, right? I can look at different things, like what could have caused this difference between those that developed lung cancer and those that didn't, right? So what's a good one I could look at? Look at cigarette smoking, right? So I can go back and I can look back to see, okay, well, this proportion of people, this number of people with lung cancer, 70% of them smoked versus 30% didn't, versus the control group, 20% of them smoked and 80% did not. Okay, well, I can start to make some inferences about that. I can say, okay, well, it looks like cigarette smoking led to these patients developing lung cancer. Now, is that going to be as strong as if I took two groups of people, none of them had lung cancer at this point, and I made some of them smoke a pack of cigarettes a day, and then the other ones I let them smoke nothing, and then look forward? Again, not ethical, but that would make you have a stronger conclusion about cause and effect than it would be if I was looking more retrospectively. But what do you think about the ease of doing a study like this? It's pretty easy, right? Because I can look backward, I can just collect data, that's no problem. So for instance, for my study, when I did it on the coral snake bites, I didn't look for new coral snake bites going forward. We only have like 50 a year that happen here in Florida, but I could look backwards in time. We had a nice database. I could have 12 years worth of data I could look at, and we had something like 300 cases I had, or even more than that. But basically, by looking retrospectively, it's a lot cheaper, it's a lot easier to do because I'm just collecting data at that point. And again, it's observational. I'm not having any direct intervention. I'm just taking data, classifying it, and then making some inferences about it. If that makes sense. Okay. And again, a case is going to be who has the outcome that I'm curious about. That's a very important aspect of this. The case control study is the case. You're starting the outcome, and then you're looking backwards to see what the risk factors, why they might have been exposed or not exposed to. Okay. All right, we're going to wrap up this session here. Any questions? Any questions at all? All right. Hopefully I've instilled some urges to read the medical literature, be pros at evaluating primary lit. Oh, we'll get more examples as we go forward. Anyway, so we talked about the case control study, which is, again, typically retrospective in nature. You can have a similar version where you'd actually have kind of the flip of that, where basically we have what we call sometimes cohort studies. Cohort is basically we're going to be dividing up people based on their risk factors, and then you look at disease outcomes in the very future, right? So again, you're starting kind of here at the beginning, and then you move forward. So for instance, in our smoking and lung cancer examples, how would you divvy up patients here? Yeah, you basically say, okay, here's all my smokers, here are my non-smokers, and then you'd follow them for a period of time and look to see, okay, well, what was their outcomes? Who got lung cancer and who didn't? Again, what do you think this is as far as resources go? More intensive, less intensive? Yeah, it's a little more intensive. It's time intensive is the thing, right? Because you're looking forward in time. So if you want to follow someone for, say, 5 years, maybe that's not long enough to determine things like lung cancer developing. Maybe you'd follow them for longer. Maybe you'd find more information out. So a lot of that can be somewhat problematic. So time is always a factor here. Sometimes you may have what they call a retrospective cohort study, where they actually will start in the past and divvy up people based on their risk factors, and then move forward to see up to the present time what were their outcomes. But that is just another variety you might see that. Typically, though, these cohort studies are going forward. Again, the cohort is made up of risk factors, whether you have it or you don't, and then you look to see what the outcomes are. Case controls, where you're starting with those that have a case, they have the outcome you're looking for, and then you look backwards to see did they have the risk factor you're interested in. Again, does it always have to be one outcome and one risk factor? Oftentimes you're looking for multiples, right? So especially if you're starting out with one risk factor, you're looking forward to see multiple different outcomes. If you're starting with one case definition, you can look backwards and look for multiple different risk factors to see what might be present there when you showed up being positive. Next up, we have what we call a cross-sectional study. And so this is kind of blending a case control and also one of these follow-up with these cohort studies together. And so typically you start with your study population. You can then kind of have different assessment outcomes and different descriptive features, or maybe possible predictors, right? So different things that may be influencing kind of the outcomes there. And so sometimes what you'll do is basically kind of run it similar to a cohort study. And then what you actually do is kind of have like a cross-section of time that you're going to take. So you may have this defined in the study protocol. We're going forward to say, okay, we're going to measure it at 3 years, 5 years, 10 years, and then you do this prevalence survey. Okay, prevalence is going to be basically the number of people at a specific time that actually have the outcome that you're interested in. Okay, so I could set this up. Say I was looking at smoking and lung cancer outcomes. I could say people who are in this case, if I wanted to do it, I could do it free disease and then have the disease. I could say maybe do it based on lung cancer. They have it or they don't. And then go forward, look to see, okay, do they have any risk factors based on that one slice of time? So you say, okay, the prevalence of smoking in this group was, say 10% versus 20%, whatever the case may be. Okay. This is done less commonly, but certainly you see a lot of case control studies, a lot of cohort studies being done out there for sure. Okay. So some questions to consider, is the design going to be more descriptive or more explanatory, right? So again, what kind of studies would need to be more explanatory, do you think? Like a case control potential I could use, but again, it's going to be more of like an interventional sort of study, right? Where I'm actually trying to say, okay, well, I made this intervention. I'm looking to see I started this med in this potential group, and I did nothing in this group. What are the outcomes, right? That's going to give you much more explanatory sort of information than it would be if I was just kind of being descriptive, right? I was just looking to see kind of what happened in a series of patients, as the case may be. So that's one thing to kind of consider there. Again, if the comparisons are being made, is the investigator observing the course of events, or are they actually doing some kind of intervention here, right? So again, this is where those observatory studies like case controls and cohort studies are going to be coming into play here, where they're just observing what's happening versus actually making some sort of intervention here, okay? Again, if the design is observational, are you starting with patients who already have the disease, or are you starting with maybe the risk factor and looking to see if they develop the disease or not, okay? And so based on that, I can kind of give you an idea if you're doing with a cohort or if you're doing with a case control study, okay? Okay, so going into more kind of interpretation of lab results. So this is where we're going to get a little bit more back into sensitivity, specificity, and the predictive value. Sensitivity, we said, was just what? Being able to pick up to see if someone, if they test positive on a test, they're actually positive, right? So if they have the disease you're actually interested in. The specificity was what? It's the opposite. We're saying if they don't have the disease, they show negative on those test results, okay? And then again, looking at the predictive value based off of our let's look at an example. Here's one where they had, basically they're looking at bacteremia occurring in young children, so say 7 to 12 months or so. And they're doing the study, they're looking at things, outcomes like, okay, well, what could be predictive if these kids had bacteremia or not? So they're looking at things like, the age of the patient. They were looking at things like white blood cell count. They were looking at things like the temperature. And they were looking to see, oh, wow, these kids actually had bacteremia. It was significant in this group here of 7 to 12-month-old patients. If they had a white count greater than 20,000, yeah, it was significant that, those patients were more likely to have bacteremia. Those all look good, right? It all kind of makes sense physiologically that, yeah, patients that have a higher fever, have a higher white count, yeah, they probably have bacteremia, right? But let's look at the actual interpretation of it, see if that can actually help us out. And then if we were to take this information and apply it to a kid who presented to the ER for possible bacteremia. So looking at this, you'll find that we kind of divvy up the patients based on the different factors we were talking about here, right? So again, looking at the age, looking at the temperature of the patient, and then also looking at the white blood cell count here. Do you see basically what they did in this study was they had these patients, they would do cultures, and so they looked to see, okay, what's their CBC look like, what's their temperature, all that, and then they looked to see whether they developed a positive culture or they didn't, okay? And so that comparison there, right, comparison whether they had positive cultures or not, kind of gave you, that was their comparison there. So they saw that when you looked at the number of patients with positive cultures in the 7 to 12 group, that, okay, yeah, that was statistically significant. They were more likely to have bacteremia as compared to kids of different age categories listed there, okay? And again, looking at that, you can see the percent positive actual results there, okay? And again, these are not overwhelmingly high, but it's one of those things where at least they were statistically significant. Clinically significant, we got to figure that out. So we're going to be looking at in more detail here. Okay? So how do we actually figure out the sensitivity and the specificity in determining this? Well, basically what we're going to do is we're going to look at our test, and we're going to see if it's positive or negative, and then we're going to look to see if the disease we have is positive or negative. In this case, what would determine if we have the disease or not? They have a positive culture, right? So based off the last slide we saw, okay, do they have a culture that's positive or no? If it's not positive, then sure they didn't have bacteremia. There could be some other confounders there, but let's just say that it was negative, right? They did not have bacteremia versus it was there. And then you're looking at the test to see whether it's positive or negative. So in this case, you could say white count greater than 20,000. Negative would be white count less than 20,000. You can say, okay, who had a white count less than 20,000 but did have a positive culture versus those that had a white count less than 20,000 but had no positive culture. Okay, so you can make these comparisons here to see what kind of sensitivity you have versus the specificity versus the predictive value. Okay, and again, I'm not going to have you actually calculate this on the test, but if I were to give you values, you can make some interpretations here. Okay. And obviously we want bigger numbers for sensitivity and specificity, right? Because that means you're more likely to have actually gotten very close to getting 100% right in these cases there, right? Because again, if you're looking at the sensitivity here, A, being the people who had a positive test and had a positive blood culture, that's what I'm actually interested in, right? Those are the people that I was actually curious about. Okay, they had this finding. Did it actually lead to an actual positive culture? And so you want this value to be very close to what the denominator is, very close to 1, okay? However, if you get a lot of false positives there, or false negatives here, you're going to find the denominator will get bigger, and then your value is going to get lower. That sensitivity is going to go down. Okay, and it's usually in a range between 0 and 1, usually as a percentage. So again, closer to 1, 100% is going to be better in these cases. That's how we calculate it. So let's put it into terms of looking at the specific outcomes here, or the different findings. Let's look at the temperature of the patient. So again, here we're looking at anything greater than 39.4 degrees centigrade versus less than, and then looking at the blood cultures here as well. Looking at the white blood cell count. So what do you kind of notice about this? Okay, well, sensitivity was 73% in the group with the temperature greater than 39.4, and it was only 29% sensitive in patients who had a white count greater than 20. So what does that kind of tell you right off the bat? Well, obviously, the temperature is more sensitive, right? So if you had a high temperature, that meant what? You were more likely to have a positive culture, okay? So that means that having a high temperature was more predictive. It was more likely you were to have a positive culture than just having a white count greater than 20, right? Because what are some other reasons you could have a high white count? Stress, it could be viral illness, it could be fungal, I mean, it could be lots of different things that could cause your white count to go up. So here you find that it was less sensitive, okay? So again, you had a lot of people who had positive blood cultures that did not have a white count less than 20, right? We also know that, in these really critically ill kids, sometimes they may not even have a high white count to correlate with their degree of illness, okay? So we see here that, okay, well, temperature tend to be more sensitive in this case here. What do you know about the specificity? So white count tended to be more specific here, 88% specific, which means that if you had a white count less than 20, this was very good. If you had a white count less than 20, you're very much more likely to have a negative culture, versus if you were just to go off of temperature alone, you'd see here that, basically they have a lower specificity here. It means that just because you had a temperature less than 39.4 doesn't mean you're necessarily going to have a negative blood culture here. Okay, so again, this test would be more specific with the white blood cell count to determine if you're more likely to have a active culture. Now again, are you going to be looking at each one of these individually to make your final diagnosis? You're going to be using these in tandem, right? You're going to be using things like the white count. You're going to be using things like CRP. You're going to be using things like different tests all together to kind of make your final diagnosis here. But this is kind of what goes into determining the individual sensitivities and specificities for each one. Okay. And so we're going to look at the predictive value, and this is going to mean here in just a second. But basically, it's saying that, okay, if you have just this finding alone, what is the probability that you're going to have the outcome that we're looking at, or in this case, a positive culture? And again, here it's 7% and 12%. Not good in either one, right? So again, you wouldn't want to use these by themselves to make your final diagnosis. So looking at this means, if you look at the temperature, it will properly identify 73% of patients who have a positive culture. So again, pretty decent sensitivity there. Although we'd like greater than that, we'd like to see close to 100. It will properly identify 55% of patients without disease or specificity. Okay, so that means if you had a temperature, less than 39.4, about 55% of the time you would identify those people who did not actually have a positive culture in the end. Okay, and this means that if you had a 7% predictive value and all those children there, that means that 7% of them, just with that finding alone, would actually have a positive culture. And again, that's not great. You don't want to just look at that alone by itself and say, okay, I want to make my diagnosis off of this. You didn't have a temperature, you don't have bacteremia. Obviously, could not be, maybe not the case there. So, and then looking at the white blood cell count, you can see here it's very specific. We're going to find that it was able to correctly say, okay, well, if you don't have a white count greater than 20, then you're more likely to not have the actual disease, not have an active culture, versus sensitivity, only 29%, right? So there could be a lot of kids you failed to identify just based off the white count alone, right? So just because you have a low white count does not mean that you were going to have a negative culture there, okay? A little bit better predictive value, but again, still not great overall. That makes some sense. Now go back through, and again, sensitivity is able to identify people who have the disease when the test is positive, and specificity is able to rule out the disease in people who are negative on that test, okay? So anyway, now again, looking at prevalence is what I said is just basically at a single point in time, what are the proportion of people that actually have the outcome that you're actually looking at here, okay? This is usually what we call the pretest probability. So as I mentioned, if you're looking at something like HIV, if you're dealing with just the general U.S. population, the prevalence is probably a lot lower than if you're dealing with, say, IV drug abusers. Everyone can probably agree with that. All right, so again, if you have a certain population, the prevalence is going to be different based on which population you're looking at. So that's typically going to be the pretest probability going into, and I can apply it to these results here. Now, once I apply the pretest probability and I kind of come through and look at the positive predictive value, this is where I'm going to get what we call the posterior probability. So then I'm going to get a better idea of what percentage is likelihood that my patient actually has the disease that I'm interested in. I'll show you an example of this in just a moment here. So again, let's say, for instance, we were looking at a policy. This was kind of a study they did a while ago where they said, the state legislatures wanted to require mandatory premarital serologic testing for HIV. Okay, basically they did this screening in Boston. They were trying to identify if this was a good idea to implement this maybe in a larger statewide or maybe nationwide sort of thing. So right, just based off of that, they're testing every single person who's going to get married for HIV. What do you think the rates would be there? Pretty high, pretty low? Just the general population, you'd assume, pretty low, right? In general, most people do not have HIV. So the thing you're going to find is that when you're dealing with populations that have a very low prevalence, you're going to find that the tests are going to be very likely to find things like false positives, false negatives, right? Versus if you're dealing with a population that has a very high prevalence. Okay, but let's see what happened here, right? So let's say we have, looking at this table here, we have people that actually had the HIV infection. Basically, again, off the gold standard that would be defining the study here versus no infection here. And then looking at the specific tests that they did on the screening, there were people that are positive, people that were negative, okay? So if you're looking at this, looking at those that actually had the true infection, you basically just total up this column right here, right? So again, the people that all had active infection, whether they're positive or negative on the test, came out to be 1348, okay, out of the total of 3.8 million. So is that pretty high prevalence, pretty low prevalence? Pretty low, right? It's only 0.035% of that population they examined actually had HIV. Very low prevalence, okay? So what they did was, when they did the test here, you can see that, okay, when they identified people versus them not having the actual infection, you actually found sensitivity was 98.3%. So what do you think that means? that test is very sensitive, meaning if you do test positive for HIV on that test, guess what? You probably have HIV, okay? Looking at the specificity is also very good here, where if you're looking at the actual people that did not have a positive test result versus all those people that did not have HIV, what do you notice here? 99.8%. So if you're negative, probably likely to not have the actual disease there, okay? However, though, look at the people that we incorrectly identified, right? We said 23 people were negative when they actually had HIV, right? Is that something you want to miss? Not really, right? It's not good. However, look at this, though. Imagine if you were subjected to this. You're about to get married to your significant other, and you had to have this mandatory screening for HIV, and all of a sudden you find that of the 3.8 million people there, 7,648 showed up positive. Is that something you want to try to explain? Because then you got to get follow-up testing to actually rule that out and find out that it actually was negative. It was a false positive, right? So because we're dealing with a population that has a very low prevalence, you know, because again, the sensitivity here is 98.3%. That's still 1.7% of those people still end up showing up positive with a false positive. So again, when you're dealing with large numbers like this, it means that you can have a high false positivity rate based off of this, okay? And again, that's not something you want to give someone a misdiagnosis on that. So we need to do kind of follow-up testing afterwards. So you can see some of the inherent problems with this. There's about almost 8,000 people you're incorrectly identifying as having HIV when they really didn't, right? So again, that's a problem. So even though you had a very high sensitivity and specificity, again, you still found there's a lot of people end up having false positives. There's a lot of people who had, or some people had false negatives, but in general, found the false positive rate was a big problem there, right? And you can call that what kind of error? The type 1 error, right? So you're saying they have the disease when they actually did not have the disease in that case there. So again, they did a secondary screening and they were able to submit that, and that's how they got their kind of confirmed diagnosis of whether the patients really had the disease or not in that case here. Now again, when they did this follow-up testing, they found it had the sensitivity 92%, specificity 95%. So even on the follow-up test, you saw 380 people falsely positive. Do you want to be one of those people? No, right? So again, there's still some inherent problems here. What you find is notice that the rate's going down significantly. So as you apply for the next test, you're going to find your false positive rate's going to go down, right? So they found was, you know, it's better to screen patients based off specific risk factors to get a better yield. So for instance, if I can maybe retool this to say, okay, well, if you have a history of IV drug abuse, what do you think the prevalence does in that case? Probably going to go up, right? Because, you know, they engage in risky behaviors. We know that they're going to be more likely to share needles and things like that. The risk for the disease is going to go up. So prevalence should be higher in that case there. So again, if you can retool it to a population where you think this is more likely, then you're going to find that those false positive results are going to be a lot less in this case. So looking at it, despite that study they did there, Illinois ended up instituting this program. And after 6 months, 8 of the 70,000 marriage licenses were still seropositive. They had a frequency of about 11 out of the 70,000 there. So what they found was that for every positive applicant, every single person they actually correctly identified as having HIV positive that wasn't diagnosed before, it cost them about 312,000 individuals. That seemed like a very cost-effective sort of thing, right? So these are some of the analysis you come into when looking at, okay, well, we have this test, it's really good, but how much does it cost? You know, like how many people do we need to test before we actually find some sort of difference here? And so in this case, this does not seem like it was very cost efficient. There may be some better ways to kind of tool it based off the prevalence of the population if you can look for something more specific than just anyone getting married in the first place, right? The best idea. So what we can do is use things like likelihood ratios. We can actually look to see, and this is actually kind of, you'll see this in a lot of different types of studies where they're looking to say, well, based on symptomatology for a patient, you know, how likelihood that if they have this finding, they're actually going to have the disease in question. And this could be good because this helps inform a lot of things like screening procedures, right? So for instance, you have someone come in with abdominal pain. Is that very specific or kind of general? There's a million things that can cause abdominal pain, right? However, with certain descriptions of it, right, or certain findings, you may be able to try to narrow it down to something more specific, right, to get to your actual diagnosis. So you can find studies that will look for likelihood ratios to say, well, if you have this particular finding, then you're this many times more likely to actually have the disease in question rather than not. So for instance here, let's look at this. Basically, this is going to involve the sensitivity and specificity here to get this likelihood ratio. It gives you just a single number. Now I can compare the capabilities of multiple tests to determine whether or not the disease in question is present, right? Here's an example where they're looking at, whether or not patients had appendicitis or not. Okay, and so you're looking at different things like right lower quadrant pain, migration, fever, etc. And you're looking at the likelihood ratios that are here. Okay, these are ordered kind of in rank from highest likelihood ratio to lowest. Okay. Again, this is all based off the sensitivity and specificity. So for instance, you had someone who showed up with vomiting. Does that mean they have appendicitis? They may, but it could be a lot of other things. It could be viral gastroenteritis. It could be lots of things. So notice here, the sensitivity and specificity are pretty poor. Okay. But as you get things that have a higher likelihood ratio, you're going to start to notice that those are going to get higher and higher. So for instance, right lower quadrant pain has a likelihood ratio of 7.6 compared to something like vomiting of 0.9. So that means that if your patient came in with right lower quadrant pain, they're 7.6 times more likely to have gotten to actually had appendicitis versus not in that comparison there. Okay, so again, these are helpful because they can kind of guide you when you're trying to decide, well, how do I decide if I can diagnose this patient or not based off of their findings, right? And this is where you get these kind of different scores and different checklists you'll go off of to be like, okay, well, they're very likely or unlikely, and you kind of move on with your differential. But again, it's directly involved with the sensitivity and specificity, okay? And again, it's not perfect. Just because you have right lower quadrant pain, does that mean you automatically have appendicitis? No, it's a lot better chances than other things like just fever, but certainly you're going to see it's much more likely there because it has a sensitivity and specificity. But again, would you want to use this as your only test? You want to look at other stuff. You want to look at the white count. You want to look at the fever. You want to look at all those different things to try to get you to a better conclusion. Okay, make sense so far? That's where likelihood ratios can be useful, because that way I can compare different things together. So I can say, well, I may not just use, nausea and vomiting by themselves, but certainly if they have a couple of these other ones here, migration, internal rigidity, that would all help me to strengthen that diagnosis there. So, like I mentioned here with the test discrimination ability, it doesn't tell the whole story with just a likelihood ratio. And so for instance, if you're looking at say migration of pain versus abdominal rigidity, both of them have a pretty good discriminating factor here, right? So again, 3.6 times more likely to be found in those that have appendicitis versus those that don't. However, migration was occurring in 75% of patients and rigidity only in 32% of patients. So we're looking at the sensitivities can be quite different there, right? So just because someone has rigidity does not mean they have appendicitis. Only 32% of those patients with rigidity actually had appendicitis. So that means that was not a very good test from a sensitivity standpoint, even though when you compare the specificity with it, get that likelihood ratio, it still was pretty good. So just know that you have to kind of look at both aspects of the puzzle there. Look at sensitivity, specificity, and the likelihood ratio. Okay. Again, both can be equally helpful, but just know that one's going to be more helpful between determining if the patient has appendicitis versus not when they're present versus when they're absent. Okay, so going more into the interpretation, let's talk about risk. What is risk? Besides a board game. So again, this is the probability of something happening to you, right? So again, if I said, risk of cardiac death in a study, like this is the proportion of people that actually develop cardiac death. If I said, risk of, you could even look at risk is not necessarily such a bad thing. Say risk of, if I put you on an antihypertensive, risk of developing a 10% reduction in blood pressure, right? Risk is going to be kind of a ubiquitous term for that proportion of whatever outcome you're actually looking. But again, when you're clenching your face with these, kind of ideas of implicit risk every single day, but again, you have to, kind of weigh the benefits versus risk of treatment all the time, right? So again, this is where it can be very useful in the literature. It'll give us an idea of, kind of what are the risks associated with some of these treatments or procedures. The risk of things developing or not developing, all these sorts of things. Now, the biggest thing you want to know here as well is the denominator. The people that are actually at risk when kind of evaluating these sorts of things, right? And we're talking about relative risk. This is where we're going to be actually dividing one risk versus another, right? So again, relative risk means relative from one group to another. And so typically when you're looking at this, we're going to see that one is kind of our demarcation for significance here, right? So we'll look at some examples of this in just a second. Typically though, when you're looking at this, the higher the risk ratio, you're going to find the stronger the association is going to be here. So high risk ratio means something is much more likely to occur than has a very low risk ratio, okay? Usually something less than 1. So looking at this, we're going to be looking at the rates of meningococcal disease in college students, okay? And so what they're looking at here, they're looking at different characteristics of these college students, and they're looking at the cases of meningococcal disease, okay? It's probably identified based off culture here. And they're looking at their population. So again, sometimes they'll try to limit the numbers by trying to do things like 8 times a million. So looking at this, they had their number of cases versus the entire population here, right? That's our denominator. That's the number of people that actually are going to be in that denominator that were at risk but did not develop the disease there, okay? And then you're looking at your risk rates. You can see that some of these things are going to be putting you more at risk than others for actually having meningococcal disease based off of this study here. So for instance, what are some of the things that maybe put you at higher risk? Just based off these numbers here, what would you expect? So again, we're taking the risk in the group that got the disease versus the did not. So anything greater than 1 means it's going to be putting you at greater risk. Anything less than 1 was actually protective in that case there. Okay, so for instance, putting things like 18 to 23-year-old non-students, they tend to be at higher risk in this case here. Okay, things like being a freshman, you're at higher risk for developing meningococcal disease, almost 2 times more likely than those that were not freshmen. Okay, looking at things like freshmen in dormitories. Oh, that one's a pretty big one, right? What do you think that is? Everyone's in the dorm spreading their cooties to one another in close proximity, right? So again, that was very high. 5.1 times the risk of developing meningococcal disease versus those that were not in dormitories. So based off of this, you can kind of say, well, what are the biggest risk factors here? What are the biggest things that imply the greatest risk for developing meningococcal disease? Okay, and so again, you have to know the population you're dealing with. You have to know the number of cases you actually had, and by dividing these out and comparing these between the different groups, you'll get these risk ratios essentially. Now, the other thing to note here is we have our confidence intervals, and so when looking at these, how could I tell if these were significant or non-significant? So if the confidence interval crosses 1 here, then it will be non-significant. Because again, this is a ratio, so I'm dividing one thing by another. So if they're the same, there's no difference. That ratio is 1. 10 divided by 10 is, a million divided by a million is 1. Does not matter. So when you do that ratio, if there's no difference between the groups, it'll be 1 basically, right? The risk is not different. So when you're looking at these confidence intervals, if it crosses 1, then you know that it's non-significant. You know that it was just found by random chance alone. So for instance here, let's look at the ones that would be non-significant. If I can find any. Of course, I don't want to put any on here. So let's say, for instance, we're looking at, say, undergraduates. It was 0.7. If this went from 0.6 up to 1.2, that would have crossed 1, and that would show me that was a non-significant finding. That was just due to random chance alone. But based off of this, as it does not cross 1, it looked like being an undergraduate was more protective as compared to some of these other groups here. Okay. So again, just know that when you're doing a ratio, 1 is going to be your threshold for that significance here, if your confidence interval encompasses that.
Goes to 1, is it significant?
Okay, yeah, so this one, yeah, actually this would be a good one. So this includes 1. So it would appear that being male conferred some sort of resistance to meningococcal disease, but because it encompasses 1, I would say that's non-significant. So that p-value is probably very close. It's probably like something like 0.052, something like very close, but then it did not actually achieve that significance because we're less than 0.05 is what we're actually looking for there. Very good question. Thank you for identifying that. Being Caucasian was also another thing that did not confer any kind of statistical significance there. Okay. And again, what your denominator is defined by how you ever get your population. So in this case, you use things like Department of Education, probably a pretty reliable source there, right? Versus if I was using like number of freshmen on Facebook, maybe not be as representative, right? So that's one of those things where you have to look at the source where you're getting that information from. Right, so looking at this, when you're looking at the different quartile ranges of these women, say low activity versus higher activity here, you actually end up getting these median values, and they're looking at things like their risk, the relative risk for coronary events. So you see here, looking at different things, you see the percentage of people who are smoking in each group, or you can look at things like history of hypertension or diabetes, and then basically you're going to look at the actual number of coronary events that happen in each of these groups here, right? So you'd expect people with more physical activity probably have fewer coronary events, right? They're probably healthier individuals here. However, you can look at the risk here. And so what do you notice about here? When you see age adjusted, what do you think that means? So we take out the factor of age, because age could be a confounder, right? If you're older, you're probably more likely to develop a coronary event versus if you're younger. So by doing that, we control for age, which means we take that out of the equation essentially. So we're just looking at the differences in physical activity. And so what do you notice here? So why is group 1 right here? That's our control group, that's our comparator, right? So that's what we're kind of comparing these other groups to. However, you're looking at increasing physical activity levels. What do you notice about the relative risk? It gets lower and lower, right? So again, looking at this, women who are in the highest activity level, based off of the definitions of the study, they said they had, their risk was 0.46 times as high as those that had the lowest activity levels of developing coronary disease. Okay, so you could say that even controlling for age, those women had fewer coronary events based off the fact that they had more exercise or more activity there. Again, that's a correlation. I can't say that one caused the other, but it gives me pretty good credence there that, hey, I probably want to get my mom to go start working out or something, right? Because that would hopefully lower her risk for coronary events. When I say multivariate, what do you think that means? This is where I can control for multiple inputs. I can look at smoking, I can look at diabetes, hypertension, I can factor all of that in. And so what do you notice here? With all the different factors accounted for, you still see that those women with the highest activity level still had some protective factors there. They were less likely to develop coronary events. So by doing that multivariate regression, that helps us because that helps to take out a lot of the confounders like smoking and diabetes and all that, and say, look, we're just looking at the exercise levels here, and this is what it's telling us. Okay. Here's another one where they were looking at, this is the Women's Health Initiative. This is a very large study. If you get into OB-GYN stuff, it's a kind of one of the landmark study. But they were looking at the outcomes of women who are on estrogens plus progestins, right? So a lot of oral contraceptives contain both estrogen and progestin, and looking at different outcomes for these women here. So again, those are on either placebo or those are on estrogen and progestin. They're looking at things like coronary events, stroke, pulmonary emboli, all those sorts of things. And so looking at these risk ratios, what do you kind of notice here? Well, it looked like, because the group we were actually interested in was the ones getting estrogen and progestin, looked like their relative risk, their risk ratio, was higher, especially for things like PE, right? PE, is one of those things you want to be cautioning, women about when you put them on oral contraceptives. Listen, you have chest pain suddenly, you get shortness of breath, anything like that, you need to go to the ER, because we know that this is going to be an inherently bigger risk for those who are not taking oral contraceptives, right? So all this information can be very useful to help us determine what is the risk that our patients are at when we put them on certain treatments. Okay. Another way we could do it would be odds ratios. These are very similarly done, but typically done in retrospective sorts of studies here. Risk ratios are typically done in more prospective studies. Okay. With odds ratios, we get very similar values here. Because we're still using a ratio, our threshold for significance is still 1. So if our confidence intervals encompass 1, it's going to be non-significant here. Okay. So here's an example going back to that meningococcal disease here, going through at our odds ratios. See here, things like being a freshman in the dormitory, all these things are going to be significant here. Again, notice this one though, active smoking had a matched odds ratio, so patients who were smokers had 1.5 times the odds of developing meningococcal disease, but notice how wide the confidence interval is. It went from 0.5, cross 1, up to 4. So we actually don't know if it's protective or it's harmful, but it's non-significant, so we can't take any results from that. So we can't really say any conclusions about smoking and its effect on meningococcal disease. Okay. Now, looking at relative risk versus attributable risk, usually when you're looking at attributable risk, you're just going to be subtracting one from another. So for instance here, if we're looking at outcomes in lung cancer, or say death rates from lung cancer versus coronary disease for heavy smokers versus non-smokers, basically what we can do for relative risk is just divide one by the other because it's relative, so it's a ratio you're going to be getting there. Versus if you're doing attributable risk, you'd actually just look at the percentages of patients who develop the outcomes here. So in this case, it would be just one minus the other, and that will give you an idea of the attributable risk. So if you see that, it's just one minus the other in this case versus actually doing a division there. They're just different ways to kind of show the same information you'll see out there in the medical literature. Numbers needed to treat. Anyone know what that is? So this is useful. It helps us to determine how many patients do I need to subject to a certain treatment or drug or whatever that case may be to get some positive results, right? So how many people do I need to treat before I start to see, some sort of positive outcome, whatever I define that to be. So for instance, here's an example. We're doing a drug called raloxifene for women for osteoporosis, okay? And we're looking at different numbers needed to treat as far as did they develop fractures or not? So how many women would I need to treat with raloxifene before I prevented one fracture? And so that's what that number I needed to treat tells me, right? And so what do you think is better, a lower number or a higher number? You usually want a lower number. If I could treat fewer patients to get a positive outcome, that's a good thing, right? If I had to treat 9 million patients to get one positive outcome, that's not very efficient, right? But if it was one, every patient I gave that drug to, they improved, then that's going to be a good thing, right? So lower numbers needed to treat are typically going to be better in this case, right? So in this case, looking at this with, say, women with low bone density and they had a prevalent vertebral fracture, so they were already coming into the study having a vertebral fracture, you found that whether they're getting raloxifene, say 60 versus 120, and they were being compared to a placebo group, you see here the number needed to treat was 16 for those with raloxifene 60. That means I'd have to treat 16 women who had low bone density in a previous fracture in order for them to prevent another fracture going forward, okay? Now, what do you see compared to someone who had no previous fracture, but low bone density? That number's a lot higher. I mean, you have to treat a lot more women before I'd actually see any kind of positive outcome. Why do you think that makes sense? they've already had a previous fracture. They're probably at risk for more fractures going forward. It kind of shows more kind of progressive disease. So that makes sense that the drug would have bigger effects for those women who are already kind of more at risk in those cases there. So again, number need to treat is very helpful. It's good to compare different therapies together. So I can say, well, I need to treat 16 women versus just 10 women with this dose here. So maybe I can use that when I'm making my calculations of like, well, what are the side effects profiles look like? What's the cost look like? We can kind of make better, kind of comparisons and make more kind of educated decisions there. Okay. Yes.
For the attributable risk, is that where for the confidence interval, if it crosses 0 instead of 1?
That's a super good point. Thank you for making mention of that. Again, low sleep. I forget about important things like that. If you're doing subtracting one risk from another, or you get that attributable risk, you're going to find that if a confidence interval encompasses 0, that's where that'll be non-significant. That's a very good point. If you're doing one thing divided by another, it's a ratio. 1 is your point of significance. If you're just subtracting one from another, then 0 is going to be your point. Okay. All right. So anyway, going back more to causes. Again, what is the confounder? So confounder is going to be anything that could be skewing my data to make me have an erroneous conclusion about the results that I'm seeing here, right? So it could be anything. So for instance, if I'm looking at, say, cigar smoking and baldness, okay? So let's look at those. So we have our cases for people that were bald, probably mostly men, men right here, versus no, they still had their hair, and looking at cigar smoking, and then looking at this relative odds, it was 6.2. So what do you think that? Do you mean cigar smoking leads to male pattern baldness? Or could there be other factors at play here? Probably, right? So it could be a lot of genetic factors. It could be a confounder. It could be things like diet. Could be a confounder. It could be, do they wear a fedora all the time? I don't know. I don't smoke cigars. I wouldn't know. But question is what are the confounders that could be there that try to explain the results you're finding? And again, this is an important part of the limitations in any study that you're reading, where they try to say, hey, this is the things we could not control for. These are the things we didn't ask about. These are the tests we did not run, so we don't know if these are playing a role for these patients as well. So again, consider and try to get the results out of. Now, let's say, for instance, we're looking at just men. Looking at the average age of the cases in the study there, was say 52. What about the average, if we just took the controls, was 24? So looking at that, 52, typically older dudes tend to smoke more cigars than younger guys. Anyone experience anything different? I don't know. So let's say, for instance, in this study, though, they found that the average age in the smokers were 52 versus 24 in the non-smokers. So what do you think? Who's more likely to be bald, older guys or younger guys? Probably the older guys, right? Maybe some unfortunate younger guys, but some older guys are more likely to be bald as well. So when you actually take that into account, you're actually looking at that, you found the relative odds for being bald with smoking was actually 0.85. So what does that mean? It looks like cigar smoking might actually be protective from balding, right? Because again, it's less than 1 because it's an odds there. So it means you're 15%, less likely to have the odds of developing baldness because of cigar smoking. At least that's what the correlation is. Again, is that causation? No, but it's just kind of an observation we've made here based on that. Okay. You have to control for confounders. These are going to be things you're going to be skewing your data one way or the other. You need to take into account. So at least address it if you can't outright control for it, right? Or if you can't, at least try to think about things beforehand when you're designing studies. To like, what are the confounders I can take into account? What are the things I'm just not going to be able to, right? Because again, they're going to have some effect on your outcomes. So looking at things like sugar consumption. So looking at patients with heart disease versus some control subjects here. We look at sugar consumption, those that had heart disease versus those that didn't. That kind of makes sense. You'd imagine people with heart disease probably have worse diets overall, so we'll see if that has anything to, what kind of confounders could be playing a role. So if we were to break that down, actually looking at this, you could actually go into more specifics here. So for instance, is sugar the only thing that affects whether you have a heart attack or not? No, it's probably playing a role, but there's probably some other confounders there. So what if we were to take those heart disease patients and figured out if they were smokers or not versus the control subject whether they were smokers or not? Now you can kind of take into account whether they're smokers and how that is going to play a role, even though you've dealt with one of those confounders. So now you can more accurately see, okay, well, does sugar have any results on this or not? Or is it just kind of an erroneous finding there? Okay, that's what one thing you can do by kind of diving down or diving a little bit deeper to get into those confounders and take those into account. So, in this case there, they found that the sugar consumption with heart disease relationship was confounded by smoking, but you end up still finding that the sugar, when accounted for, still led to those increased results as well, right? So again, sometimes you can find the confounders are playing a role, but again, they're going to be interacting with probably what you're looking at as well. So it's important to look at all of those things. So now we see that sugar and smoking affect heart problems. So, and again, this is where multivariate analysis can be very useful here. So as I mentioned, with looking at the different activity levels for those women, by having that multivariate analysis, we can take into account things like history of hypertension, diabetes, hypercholesterolemia, all these different things that could be affecting their cardiac outcomes. By doing that, you can just kind of isolate those results and say, okay, I just want to look at physical activity and looking at the coronary events, right? You can do this as well, looking at things like dose response. So again, looking at endometrial cancer rates with estrogen use in women, looking to see like, okay, well, what kind of different use do they have, and how, what are the different risk ratios that it can develop here, right? So in this case, you can see actual dose response relationship where if you're taking more than 0.6 milligrams per day, you had a pretty high relative risk of developing endometrial cancer, right? That's why you always give progestins along with estrogens whenever you have these women on these products here. But again, looking at the confidence intervals you see here, because it's a relative risk, it's greater than 1. It's going to be significant. Okay. Okay. So some other questions to consider. Have the authors at least addressed the possibility of chance or of bias in their study? They talk about the different factors that could be involved that they did not account for. And then once they've identified, is the list pretty reasonable? Does it seem like things that once you get into a certain field, certain specialty, you kind of get more in-depth knowledge on it. You'll kind of know, like, wait a second, they didn't even think about this other thing that could obviously be affecting their patients, right? And just consider what kind of effect could those uncontrolled confounders be playing a role here. And then have they taken steps to account for the confounding? This is when you can do things like multivariate analysis to try to control for those sorts of things. And then once they've kind of shown, they've at least taken some steps there, did they have any additional evidence to show that maybe these other effects are causing some degree of causality here, okay? Again, looking at things like, strength of the association, biological plausibility, et cetera, right? Just because cigarette smoking probably doesn't have any true effects on baldness, but, confounding or taking into account the age, you saw, there's some very different results there. Okay. So any questions on that? As I said, this is the end of the material for test 1. You can go and review those videos if you've not watched those. They'll inform a lot of what we talked about today. I will post a review in the upcoming days. I will put an announcement out when I do that, along with a Kahoot, so you can kind of do it along with me as I'm going through it. And any questions, I can answer for you in the meantime. I'm very sorry I didn't go all the way to 11:50, but please use this time well. I'll see you later.